Let me first introduce Dr. Snehal Shah to everybody. Dr. Snehal Shah is consultant head and neck surgeon at Prince Ali Khan Hospital and Safi Hospital. Along with that, he's working at Beach Candy as well. He has done his MCH in head and neck surgery from Tata Memorial Hospital, Mumbai. Today's topic of discussion is minor salivary gland of oral cavity. And before we start the case discussion, Dr. Snehal will be presenting on minor salivary gland tumors of oral cavity, basic management and basic approach towards the tumor of towards this tumor. I think we can start, Dr. Snail.
Yeah. So, good evening, everybody. We'll be talking on minor salivary gland tumors of oral cavity. So, coming to demographics, salivary gland tumors comprise about 3 to 5% of head and neck cancer burden. 15 to 20% of the salivary gland tumors are minor salivary gland tumor cancers. Large majority are malignant, about 60 to 80% in most of the series. The commonest site is hard palate for oral cavity. Now, this is actually a mixed bag. 24 to 25 malignancies with varied tumor biology and a consequent clinical behavior. Etiology, genetic mutations, transformations, rearrangements are very common. They are implicated for minor salivary gland tumors. Apart from the viral infections like cytomegalovirus now has been implicated for mucopollular carcinoma, but herpes virus, papillomavirus, EBV are also implicated. Exposure to chemicals, now this is more to do with nasal cavity and appendicitis tumors where you have adenocarcinomas arising from salivary glands on exposure to nickel or chromium. Ionizing radiation, you will have, especially for those where malignancies arising from salivary glands and they are probably implicated. Now, coming to clinical presentation, most common is 4 to 7 decades of life. Female preponderance, the ratio is 1:1.19 to 1:1.2. The most common presentation is painless submucosal mass. There could be numbness of teeth or a long-lasting ulcer over the palate, buccal mucosa, or lip. Nodal metastasis rate is less than 10% by and large, but for some it might go to 15 to 20% as well if there is high-grade transformation. Overall, at presentation, the distant metastasis accounts to 1%, but overall it is 30%. Coming to imaging, the imaging of choice is an MRI, especially the post-contrast MRI sequences on T2, where you actually calculate for Tmax, a time taken for the dye to concentrate. That can distinguish between benign and a malignant tumors. Of course, MRI will help improve soft tissue delineation, can highlight perinodal invasion, bone marrow involvement, neck node disease mapping, recurrent tumors. CT scan, by and large, is combined with MRI to see for any distant mets or for bone erosions. The role of PET-CT today is understudied, although for major salivary glands, the PET-CT has been done to see for distant mets, but in minor salivary gland tumors, again, the role it's not well studied. Probably it could be used again for residual recurrent or for distant metastasis. Biopsy. We do an incisional biopsy from the lip, palate, or buccal mucosa. It's a biopsy of choice over the FNA or over the punch biopsy as well. Now, the advantage of doing incisional biopsy is, first of all, the site is very much accessible, so you get a lot of tissue, where you can also assess for the grade. The grade is one of the important prognostic factors. Grade can be decided by the amount of tissue that we get. The histology, the histotypes, whether it is benign or malignant, may be difficult because of the overlapping histological features. But yes, you can get tumor architecture. You can see for necrosis. You can see for pleomorphism, nuclear pleomorphism, mitosis, which can detect for grade. The most important thing is you will also get the tissue for doing a molecular workup for those patients. And last, maybe it is said when you compare a squamous carcinoma with the salivary gland tumors, the gland tumors have got a pushing borders by and large rather than infiltrating. So you will also get the basement membrane to see for any invasion, if at all it is, which might help to distinguish between a benign and a malignant. FNA is sometimes performed intraorally as well. Now, this is in brief WHO classification of salivary gland tumors 2017. Just to highlight, there are a few newly added entities which have added and which have increased the headache of the pathologist. 2 or 3 pathologists, they come up with the diagnosis. It's difficult because these tumors are very rare and they're challenging enough. Now coming to treatment, we have 3 modalities: surgery, radiation, and a chemotherapy. Now surgery, what they say is the surgery is a treatment of choice. We do a wide local excision with adequate surgical margins, free clear margins. What do we mean by adequate clear margins is not yet sure, but they do. But majority of series which have covered, they have said 5 millimeters or 1 centimeter. When they compare, this is squamous carcinoma, where they say 15 millimeter margin would be quite adequate. This is because the biology of salivary tumors is quite better. They do better as compared to squamous carcinoma. Coming to neck dissection is performed for T3, T4 tumors. They are performed for neck node positive tumors, high-grade tumors, or for that matter, those tumors which are where you require to do a free flap reconstruction. You may not do for a T1, T2 tumors, or where the probability of nodal metastasis is up to 50 to 20%. Coming to radiation, radical radiation, radiotherapy, and adjuvant radiotherapy plus minus chemotherapy. I will come to that over a bit of time. And a chemotherapy could be adjuvant or palliative, but mainly there's a role for palliative than an adjuvant chemotherapy as of now, but we'll come down as we go about. So let us discuss the literature for this particular minor organ tumors. Wait, it just got hanged. Sorry. So we start with quite an old article, the work retrospective study done by the Mexican group. Retrospective study of 77 patients. They did a univariate and multiple analysis, and they found out they had calculated for DFS. Now DFS for 77 patients was they found out the 4 prognostic factors, independent prognostic factors. The first was the tumor size. If you see, they have shown the DFS being significantly different for various tumor sizes. The TNM classification for minor salivary gland is on the lines of oral cavity. So less than 2 to 4 or more than 4 centimeters. But if you see here, they've split the tumor sizes into less than 2 to 4, 4 to 6 or more than 6 centimeters. And they found that DFS is poorer for tumors which are more than 6 centimeters. The second, adjacent to the right side, DFS, they saw for the grade. Now they again found that poor and undifferentiated as advanced grades, and early grades as well in moderate differentiated. Poor and undifferentiated as expected did poorer. Thirdly, they came on to the histopathology, and again, depending on the type of histopathology, they again found the difference in the DFS. And so was a case for positive margins. Very few papers have found significance of positive margins, but this paper did show that positive margin itself acted as an independent predictor on a multivariate analysis affecting a DFS. However, this is again for node and for T sizes. But all said and done, overall, the DFS for this kind of tumors is much, much better. It is in the lines of 70-75% over 3 to 5 years, whereas which is different otherwise for this same setting for squamous cell carcinoma, which is much poorer. They also found for recurrence-free survival associated with prognostic factors by Cox method, and they found again the surgical margins, tumor diameter, status, grade. Now, not all studies are showing grade as a positive prognostic factor, but yes, many of them do. Now, this is something by the stalwarts of our hospital, our institute, India, by Dr. Abhishek Vaidya. This article came. So we started with a sample size of 77. This was a paper which was done from our own hospital, the sample size of 104 patients. And they found out, so the data which was calculated was, analyzed was between 1990 to 2004. And they did a univariate and multivariate analysis for the MSGs. And they found out that on a multivariate analysis, T state, that is a tumor stage, T3, T4 did worse than T1, T2. It was significant prognosticator. So was the grade. So was the adjuvant radiotherapy. Now, this was the first paper to find out, to show that adjuvant radiotherapy does impact survival. It does improve the survival in those kind of patients. Most of the patients with MSGs, minor cell gland tumors, would land up requiring adjuvant radiotherapy. We'll come on to that subsequently. They also showed this, discussing about the same paper, they also showed that the DFS and OS was significantly better for a non-ACC, non-adenoid cystic carcinoma patient as against adenoid cystic carcinoma. And of course, overall survival and DFS were far more better, far more higher. Now here, the overall survival was better than the DFS in this paper. Now this indicated that even though there's a recurrence, these recurrences are very much salvageable. The biology is not as aggressive. Even with distant mets, patients will have survival up to 40% by 10 years, or might drop to just 30, but it will not be as against squamous carcinoma. Again, here, coming further, they also compared DFS with grade, and they again found this. So they clubbed it, low and intermediate as one group and high as another, and they found again that high grade tumors did poor with DFS as against the low and intermediate. Then came after 77, 104, we have come higher up, seeking a SEER database where they saw for survival in oral cavity, total 639 patients. Females were about 55%. Most common was mucoepidermoid, followed by adenoid cystic carcinoma. In the prior paper, adenoid cystic carcinoma was much more common than mucoepidermoid. But by and large, in the palette, you find more of mucoepidermoid than adenoid cystic in most of the series. Now, site was hard palate and gum, which are most common. T1 and T4 predominated. N0 was in 93%. Oral survival was found in 158 months. Now, again, they found out on multivariate analysis the significance of N stage, T stage, male sex. So they divided the male sex, and then the age. Age was also found to be significant. They divided the age into less than 59, 59 to 73, and more than 73. And they found that those with more than 73 did poorer as compared to other age groups. Grades, again here, were not found to be as significant, apart from intermediate grade MEC, which did as much as high grade MEC. So grade did not find its place in this paper as being independent prognosticator for the outcome. Now, further coming down, the recent paper which came out was by Ian again, who used a SEER database from 2004 2015, and they devised a nomogram. What is a nomogram? A nomogram is a handy statistical tool for predicting a probability of a specific outcome in oncology, and it has shown its power in survival predictions, which may have opportunity to replace a TNM. But then the nomogram not only takes TNM into the account, it takes multi-factors. And that's why whether it would be validated or not is quite controversial. But yes, they had they made nomogram for 1,700 odd patients. They estimated 3 and 5 year overall survival and a cause-specific survival. And the concordance C index for internal external validation, what they found was as 0.8. So something which is more than 0.7 is found to be quite significant. This was 0.8. The discriminatory ability, apart from C index, the discriminatory ability of a nomogram was clearly superior to TNM. We'll go further and see how it is. I'm not going into much of this, but these were the multi-factors that they took into account after univariate and analysis. And based on that, based on the site, based on the age, grade, TNM, and surgery, they devised a scoring system divided into 3 groups: low risk, intermediate, and a high risk group. And based on that, they started calculating on the mathematical model, this patient plays, is he intermediate or a high grade? Based on that, they said that those with a low grade might be observed, they might not require any adjuvant treatment. Those with intermediate grade would be kept on a close observation, and those with high grade would undergo a radiation adjuvant. Now, this is again C indexes, and this was comparison of their model with that of TNM stage, and they found it was quite significant. In fact, TNM did equally well, but TNM was inferior to nomogram, as we see here, for OS and for cause-specific survival. Coming to adjuvant radiation, indications are T3 and T4 lesions, intermediate high grade, positive or close margins, perineural invasion, Neck node disease, yes. Whether to add chemo or not to add is still controversial. The trial, the accrual for RTOG 108 is still going on. We are awaiting the result. Now, this was the first paper which showed a survival benefit for adjuvant radiation in minor salivary gland cancers. So, a lot of statistical analysis and play around with statistics. And they found this is a nomogram. This is a curve which is showing a nomogram with the graph plotted, and that with a red is a PTX based after. So what they did was they did they had they actually computed for other prognostic factors. They ruled out those, and they tried to only study the role of adjuvant RT, where they found a benefit for the patients. Now, radical radiotherapy, the indications are unresectable, inoperable tumors, or where the cosmic deficit is too huge, where you will not get a R0, or maybe cosmic deficit is so bad that that surgeon must decide whether to go ahead with resection or not. And in those with medical comorbidities that would not tolerate, or those patients have declined surgery. So these are three indications for radical radiotherapy. As for chemotherapy, mainly palliation for inoperable, unresectable tumors, and for disseminated metastatic disease. Before coming to that, we do offer surgeries for those patients with distant mets who have got good general condition, and they say that primary tumor surgery, PTS, the outcomes are superior for over 1 to 2 years as compared to when you don't operate this kind of patients. Of course, you take into account other factors like cosmetic deficit or how morbid the resection would be. But otherwise, if there are distant mets, maybe oligomets, you operate. But if there's distant mets, you would like to be prudent enough to decide whether to go ahead with surgery or not. But there is a data on that it does help improve survival by 1 to. This is, you may not go in detail, but these are a number of studies based on a molecular studies, the kind of mutations that you find, and the targeted therapies, the immunotherapies which are being tried for all the patients. So in brief nutshell, for adenoid cystic carcinoma, these are the therapies, targeted therapy. We have cyclophosphate cap-based regimen and immunotherapy which has been used. So mainly these are the therapies which are used for mucoepidermoid, adenoid cystic carcinoma, and for SDCs, for salivary duct carcinomas, adenocarcinoma that was specified. Thank you so much. But this is what, in a brief nutshell, we have for minus.
Thank you, Dr. Snell, first of all, for very informative and very detailed presentation on this very difficult topic, because the data is definitely sparse on this topic. Before we move ahead, I would like to invite all our examiners for the session. First of all, I would like to invite Dr. Elizabeth Matthew, IP Madam, Professor, Surgical Oncology, Regional Cancer Center, Thiruvananthapuram. Madam, are you there?
Yes, good evening.
Yes, ma'am. Thank you, ma'am. Dr. Abhishek Vaid, Consultant Head and Neck Oncology at National Cancer Institute, Nagpur.
Hello, everyone. Thank you for having me here.
Thank you, sir. Dr. Karan Subaiya, sir is Consultant Head and Neck Oncology at Apollo Hospitals, Chennai. Dr. Lakshmi Narasimhan Parsuraman, Consultant and In Charge Head and Neck Oncology at Sri Ram Chandra Medical College, Chennai. Hello, sir.
Hi, man. Good evening. Yeah.
Hi. Today, our presenter is Dr. Gopi Reddy from B. Barua Cancer Institute. He is going to present on the topic minor salivary gland tumor of oral cavity.
Can I start this webinar? Yeah, Gopi, start.
Yeah, just wanted to know from the organizers. So, are you going to present it like a case for the exam? So, can we interrupt you in between, or should we come back to you with questions at the end?
No, just like the examination, please go ahead and ask questions in between. Yeah, it should be an interactive session so that everybody learns, not only the student but also the examiners and ourselves as well.
Yeah, it's an absolutely exam-based pattern. How we present an exam and the examiner can interrupt at any point of time.
Yeah, this is Dr. Gopi from BBCI. I'm second year MCS in Department of Head and Neck Surgery, BBCI, unit of TMS. Yeah, my case is a 50-year-old male who is a resident of Kamrup district, Assam, who is a farmer by occupation, who presented to our OPD with complaints of growth in oral cavity for 5 months, change in voice for 2 months, and difficulty in swallowing for 2 months. Coming to the history of present illness, the patient had a history of swelling growth in the oral cavity for 5 months, which was insidious in onset, gradually progressive. no aggravating or relieving factor. Voice change for 2 months, insidious in onset, progressive in nature, muffled in character, no aggravating or relieving factors for the voice change. And there was history of swallowing difficulty. Difficulty was with foods. There was typing error. Sorry for it. Difficulty with solid foods and no difficulty with liquids. No history of any oral bleeding. No history of any pain during swallowing. No history of any pain in the ear. No history of any significant loss in the weight and appetite. Coming to the past history, there are no history of any comorbidities. No history of coronary artery disease, bronchial asthma, pulmonary tuberculosis, epilepsy, diabetes mellitus, or hypertension. No history of any similar complaints in the past. No history of any cancer. No history of any radiation exposure to the patient. Coming to personal history, patient is a farmer by occupation with addictions of gutka chewing for 20 years, with history of alcoholism for 20 years, about 30 ml per day, and 5 days a week. This is still the history part. Am I audible, sir?
Yes, you go ahead. Yeah.
So, Dr. Gopi, what do you think has caused the change in voice?
Sir, actually, the patient is having a growth completely in the oral cavity, filling the oral cavity, sir. So the patient was initially having changing voice with almost loss of voice when the patient presented to us.
Dr. Gopi, you said change in voice. What sort of change in voice they were telling, like hoarse voice?
Initially, the voice was muffled. The patient was speaking muffled voice. Now the patient is saying he can barely speak with the growth because of restricted tongue movements.
Okay. We are just discussing the history only now. So we are not, yeah. And why did you ask about the referred pain? What is the basic cause of this referred pain, referred otolgia?
Referred otolgia, ma'am, they can look for any involvement in the base tongue, oropharyngeal extension.
Okay.
So is base tongue the only site? Is base tongue the only site which can cause a referred otolgia?
No, there's PFS or PFS tongue, base tongue, and PFS.
So can you quickly enumerate the sites and the pathways?
Yes, sir. In PFS, we have the vagus nerve, which forms the tympanic plexus in the middle ear. So when there's a lesion in the PFS, the patient will complain of deep-seated pain in the ear. And in the coming to the base tongue, the pain is due.
It should be answered as afferent, nucleus, and efferent.
Oh, sorry.
Okay. So this is just for you to remember.
Yes, sir. The afferent is vagus, ganglion is otic ganglion, and the efferent is again vagus in the PFS.
Okay.
What branch of vagus?
Sir.
What branch of vagus? Efferent?
Efferent, superior laryngeus.
Efferent.
That's an afferent. You're talking about PFS. You're talking about referred otolgia.
Yes, sir.
You have an efferent, which you said superior. What is an efferent? What is an efferent? Where is an efferent? In the ear. Where? And what efferent now?
In ears, sir, there is tympanic plexus that is formed by the otic ganglion, around the promontory.
Would you read all three circuits? Would you read all three? You need to know, as doctor said, efferent, you should know everything. Arnold's now, where exactly is the pain? It's a deep-seated pain flow. You need to know all this for all three networks, all three circuits.
Yes, sir.
Just brush up that. Go ahead, Gopi.
Coming to the general and systemic examination, the patient had a good PS score of 1, cardiovascular system, central nervous system, pulmonary system examination within the normal limit. This is the clinical picture of the patient with the lesion. Specific examination, inspection, oral cavity around 18 to 7 centimeters, smooth surface growth occupying the whole oral cavity, pushing the tongue superiorly, laterally, and posteriorly. Posterior extent cannot be seen. Anteriorly abutting the mandible. Teeth on the lower alveolus were loosely attached. On palpation, all inspected findings were confirmed. Consistency of the growth was soft. Posterior extent of the lesion is well defined, just abutting the anterior fossa villi. Rest of the examination within the normal, no pain or hypaesthesia.
Dr. Gopi, at the end of your inspection and palpation, you should be able to arrive at what is the epicenter. You said that it is filling the oral cavity and pushing the tongue, but where is it arising from? What is the epicenter?
It's arising from the floor of mouth, medial to the mandibles.
Correct. So you should say that. So I would say it's a submucosal growth in the floor of the mouth, pushing the tongue and occupying the. So that is how you should describe it, right?
Coming to the examination of an inspection, tracheas in midline, external laryngeal framework looks normal, no thyroid cartilage spring, no swelling seen, skin normal, no abnormal veins, pulsation seen. Palpation of the neck, inspected findings were confirmed, no tenderness, no laryngeal cryptus present, no palpable neck nodes, carotid pulsations felt normal on both sides. Ideal could not be done.
Dr. Gopi, I think your oral examination is incomplete. Actually, it has to be a more extensive or elaborate description of the finding. Like first you start with the oral hygiene, the denture, the status of the teeth, and the other subsides. And you said about a soft mass in the submucosal swelling in the floor of the mouth, and on palpation, whether it is tender, bleeds to touch. The consistency you said, and the measurement you said, but other things I said it's missing in your examination finding. All those aspects like size, shape, mobility, tenderness, bleeds to touch, all those things has to be there. The extent you have told.
Right.
And palpation, yeah, you just move on to palpation. Yeah, bleeding or tenderness you didn't mention. And okay.
So in addition to what Elizabeth ma'am said, a very pertinent point in examination in this case is bimanual palpation. Did you do it?
Yes, sir.
Why? So you did not mention it though. So what is the importance?
So for bimanual palpation, I could rule out SMG, submandibular gland involvement, basically submandibular gland involvement, and if possible involvement of sublingual space also. And posteriorly, if there is any involvement of parapharyngeal spaces and all.
So for submucosal lesions in the floor of mouth, this is an important part of your examination.
Yes.
You need to understand whether the lesion is arising from or extending to the submandibular gland. Has it crossed the mylohyoid?
And what about the movement of the tongue?
The movement of the tongue is restricted.
Which side of the tongue is deviated to the right or left? And
The tongue is deviated to the left side, superiorly, posteriorly.
Okay, it's just the mass effect, not you didn't
Yes, sir.
examine for cranial nerve palsies like hypoglossal nerve palsy, anything you could examine?
Ma'am, I told spinal nervous system examination is within normal limits.
It is actually difficult to see with the huge tumor growth filling up the oral cavity. Huge growth filling up the oral cavity may be difficult to see where the tongue is deviated. More of a mass effect. It's a huge growth, so it's more of a mass effect. I mean, rather if you can say about any bundle involvement and all posteriorly, but
Yeah, what about the oropharynx? You said extending up to the anterior phalangeal pillar. Base tongue is free, soft palate is free, pharyngeal
Yes,
walls.
Yes, ma'am.
So did you do the ideal examination or a 70-degree scoping?
No, ma'am, ideal could not be done. Actually, I was unable to pass the scope.
Okay, continue.
So coming to the case summary, 50-year-old male presented with complaints of swelling in the oral cavity for 5 months, not associated with pain, fever, and dyspnea. On examination of the oral cavity, there is a smooth surface swelling arising from the floor of mouth, which is around 18 to 6 centimeters, filling entire oral cavity, pushing the tongue superiorly, laterally, and backward, just abutting the mandible is seen. On examination, neck is within normal limits. The rest of the ENT examination is within normal limits.
So what would you want to do next? What are a few differential diagnoses that you can think about based on this presentation, and what would you want to do next?
Sir, my differential diagnosis was initially it can be based on the gross appearance. It can be a salivary gland tumor, and rarely it is a squamous cell carcinoma. So mostly, if it's a salivary gland tumor, it can be either from the sublingual space or minor salivary gland. So it's difficult to differentiate between those two based on the clinical examination. So I would like to go for an incisional biopsy or an FNAC, depending upon the availability.
so wouldn't you want to image before? Would you image before or do a biopsy before? And what's the thought process of yours?
Actually, in this kind of growth where the growth is particularly big enough, there won't be any difference by doing imaging prior or imaging later to the
Okay,
biopsy.
then what made you do the biopsy first?
Logistical issues. Biopsy imaging, actually there's a lot of waiting, but actually this patient is planned for MRI today, but he didn't turn up, and I couldn't provide the imaging for this case.
So any other differential diagnosis? You said squamous cell carcinoma, salivary gland tumor. Any other differential diagnosis?
There can be a soft growth that is arising from the mandible part. Central there can be central pleomorphic adenomas, which are a kind of pleomorphic adenomas but arise from the mandible without any association with the salivary glands, which is very rare part but present in males, which are around 50 to 60 years of age. And ameloblastomas, the lesions of the mandible can also be a part, but usually the mandibular lesions are hard, bony hard, except the central pleomorphic adenoma, which can be smooth.
So Dr. Gopi, you did a biopsy here. What kind of biopsy was it?
Incisional biopsy. We did a small part of incisional biopsy.
So for a submucosal lesion, when there is no mucosal ulceration,
Yes, sir.
and biopsy would have required you to do an open the mucosa and then take a biopsy.
Sure.
I just want to know, what are the different tissue diagnosis modalities possible? What are the advantages and disadvantages of each?
Yes, sir. Actually, the literature starts quoting from FNAC, core cut biopsy, and incisional biopsy, followed by excisional biopsy. Sir. There are 4 kinds of investigation as mentioned in the literature. But when we come to FNAC, the literature says that FNAC cannot differentiate between adenoid cystic pleomorphic adenoma and the polymorphous low-grade adenocarcinoma. So they need more amount of tissue to differentiate both two. Then if we go to core cut biopsies, except in this case
so Dr. Gopi, I would like you to rephrase that answer. What is the sensitivity and specificity of FNAC for salivary gland tumors?
Sir, 60 to 89%, as quoted, mostly in the range of 60 to 80.
Okay. The way I would answer it is the sensitivity and specificity of FNAC for salivary gland lesions is excellent to differentiate between inflammatory and neoplastic.
Yes,
between the neoplastic, it is intermediate sensitivity and the specificity to differentiate between malignant and benign. And
yes,
between malignant, to differentiate between grade, it's quite low.
Yes, sir.
And that is why you need a biopsy.
Yes,
See, what happens in salivary glands, there are many benign malignant look-alike pairs, like you just mentioned.
Yes, sir.
And therefore, FNAC might not be sufficient. So if you would answer this way, that the accuracy of FNAC to differentiate between inflammatory and neoplastic is high, but between neoplastic, benign and malignant is only moderate.
Yes, sir.
And that's why you need a biopsy, especially in these minor salivary gland.
So Gopi, just since we have opened up this, what is a needle tip biopsy? Any idea?
Sir, I didn't get it.
Needle tip biopsy. Any idea? Needle tip. Search. It is for benign conditions of salivary gland, but just search it, because if you enumerate incisional biopsy, punch biopsy, FNAB, is one thing, needle tip biopsy as well. Just look into it.
I'll check it out.
What about core biopsy? What is the role of core biopsy?
Yes, sir, in this kind of lesion where we don't have anything there, the major disadvantage of doing a core biopsy is tumor seeding and tumor spillage. So there we have
what is the incidence? There has been a recent paper, not too recent, about the incidence of there has been a paper about the incidence of
36% tumor spillage by core cut biopsy if we do it in parotid gland tumor.
Can you just quote this reference?
Actually, I remember the percent.
So I would refer to a meta-analysis by Schmid, and maybe you can read that.
Yes, sir.
Yeah, go on.
So should I continue core biopsy, sir, or should I proceed with the presentation, sir? Am I audible, sir?
Dr. Gopi, what sort of ancillary testing you can do on your FNACs or core biopsies to differentiate the different histological types?
Ancillary, flow cytometry usually can differentiate, followed by immunohistochemistry.
So what sort of molecular markers, can you enumerate the histological types and the different markers you see in each type?
Yes, ma'am. In case of adenoid cystic carcinoma like this, we can check for alpha amylase activity by IHC, which is usually confirmatory for adenoid cystic carcinoma. Then collagen 4 and fibrolamin in adenocarcinomas can be confirmatory.
Are they diagnostic? Are they clinching?
They can
differentiate. Non-specific markers. Are they clinching that this could be adenocarcinoma? Okay.
Sir.
So what madam is asking, what are the specific mutations and what do you see? What do you see in that molecular basis? What are the other markers?
There are different genetic markers or mutations in each histological types. Yeah. So you should have an idea about each.
Non-adenocarcinomas, we have NTRK4.
Yes, ETV6, NTRK4. So read into this. The huge list. There's huge list. It is also for SDC as well.
ASCO guidelines quotes only, as per ASCO guidelines, they mention only doing of NTRK6 score to differentiate between adenocarcinoma and non-adenocarcinoma, adenoid cystic carcinomas, just to go for chemotherapy sensitivity.
So what is there specific for adenoid cystic carcinoma by immunohistochemistry?
Mutational marker.
Yeah. So what is the specific mutation you can detect in adenoid cystic carcinoma, which you can detect by immunohistochemistry? Just read about it. And I think it's MIB testing. And for salivary duct carcinoma, you might be knowing. It's the HER2 androgen receptor positivity. For acinic cell carcinoma, it's DOG1. So these are some examples. So you can go about it and read about it.
Yes,
did you get the grade of adenoid cystic carcinoma in this patient?
Yes, sir. The reports, actually, it's the preliminary report, sir. The patient has just turned up one in 3 days back. So we went, it's getting...
Gopi, who was Xanto?
Yes,
who was Xanto? What did he give?
The adenoid carcinoma gradings are actually, if you look into literature, there are 4 types of grading that are given from Xanthosorini to Spiro, then came AFIP, then came now mini max grading is given. As per the
Cystic carcinoma, what are the 3 different grades?
Yes, sir. Depending upon the solid component of the adenoid cystic carcinoma, they are divided into 3 parts. One is tubular, cribriform, followed by solid. Cribriform being the most common and solid be having the worst prognosis, and high, huge, aggressive, and being metastatic component with metastasis. The incidence of cribriform is around 45%, followed by tubular.
So what is low grade? What is low grade? Adenoid cystic carcinoma. So you have low grade, which is either tubular or cribriform component only.
And less than
30%. Where you have cribriform with less than 30%.
30% of the solid component.
And the third is high grade, where you have more than 30% solid component. That's how you decide the grades.
Yes.
Yeah. Go ahead.
So imaging is planned for today, sir, but the patient didn't turn up. I'm sorry, I couldn't provide imaging. The patient was planned for an contrast-enhanced MRI imaging, sir.
Go ahead. Go ahead.
USG abdomen was done, sir, which is within normal limits. And chest X diagnosis, sir, adenoid cystic carcinoma of very minor salivary gland or floor of mouth with a staging of clinical staging of T4A M0 M0.
Why do you say
why T4A?
T4A?
Yeah, why T4A? I would agree. Why T4A?
Sir, actually, if it's a minor salivary gland tumor, it should be staged according to the site there is an origin. So I staged it according to the oral cavity cancer, and as the mandible is having loose tooth, and there is expansion of the mandible as per we felt loose tooth. That I thought there is an erosion of the mandible clinically. So with the erosion of mandible in the oral cavity cancer, the staging usually becomes T4A. So
did you do EUA? Did you do EUA to see for the erosion of the mandible?
Yes, sir. The patient is planned.
Is the disease of the mandible?
Pardon, sir. You are inaudible, sir.
Did you do a EUA examination under anesthesia? Did you do that?
No, actually, sir. The teeth are
you don't have imaging, and
actually the teeth are very loose and they are mobile even.
No, Gopi. This loosening could be because of gingivitis. Who knows? He has had a poor oral hygiene, huge tumor mass. He is not able to take care of his dental hygiene. So we don't have imaging. So how do we decide that loosening of tooth is because of the bone involvement? Hannah?
Yes.
Yes. So what are the specific features of a bone erosion by your clinical examination? When will you say that bone is involved by your clinical examination?
The confirmatory is usually pathological fracture by the bone.
Pathological fracture.
Pathological fracture.
Any other early invasion of the bone invasion, mandibular invasion by your clinical examination? No, forget about this. Suppose if you have a squamous cell carcinoma of the oral cavity, how will you say it as T4A by your clinical examination?
T4A, only there can be loosening of teeth, pain along the T4A, pain, pathological fracture, loosening of teeth.
And I asked about early features. Pathological fracture may be a late feature. So whether it is stuck to your mandibular periosteum or if involving more than 2 surfaces of the bone, or if there is a paramandibular extension, all these are features of clinical finding of a bone invasion without a radiological assessment. So loosening of teeth or multiple loosened teeth as seen in this case is not really confirmatory of a T4 lesion. So as Dr. Snehal was telling you, this may be because of the poor oral hygiene, that gingivitis and all. So it doesn't mean that it is T4 in this case. Okay, what are the other features of T4? When to stage it as T4 other than the bone invasion?
Involvement of forms T4A.
Involvement of the bone?
Floor of mouth. Floor of mouth.
Bone. Yeah.
Floor of mouth itself forms a skin, bone, floor of mouth, nerve.
So for a lesion of the floor of the mouth?
Yes, sir. As per the agency, floor of mouth lesion itself makes it T4A.
Really?
What is your latest AJCC classification for T4A?
Is
Is there any size criteria?
Size criteria for T4A, sir?
Yeah, is there any? You tell me.
Sir, actually, depth of invasion more than 20 was given, but it's not updated in the HSCC 8.
Okay. So you need to read up your AJCC 8 also once again, okay?
You need to brush up this.
Okay.
What is the common size of site for minor salivary gland tumor in the oral cavity? You said this is floor of mouth lesion.
Yes, ma'am.
Yeah, what is the commonest size you see? The minor
it's actually hard palate, followed by upper lip, followed by buccal mucosa, followed by rest of the areas.
Okay. Why commonest in hard palate?
Because the most of the minor salivary glands are in the hard palate. Incidence of and any.
Yeah.
Okay, do you want to exclude a lymphoma or a sarcoma in this case? You said just squamous cell carcinoma and minor salivary gland tumor.
Yes, ma'am. Lymphoma and sarcoma, basically the gross appearance of lymphomas and sarcomas can be smooth, but with the prolonged duration of 5 months, lymphomas and sarcomas are usually differentiated by the incisional biopsy itself.
What are the specific features clinically, whether you can come to a conclusion of a salivary gland malignancy compared to a squamous cell carcinoma, the specific differentiating features between the two clinically?
Coming to the appearance, one is gross appearance.
What sort of gross appearance for the salivary gland?
Salivary gland tumors are usually well defined and smooth, lobulated. And whereas squamous cell carcinoma is ulcerative, ulceroproliferative, or infiltrative kind of growth.
Yeah, smooth submucosal, well encapsulated. And the other one is ulcerated or proliferative disease.
Yes.
Okay.
And usually salivary gland tumors are usually expansile kind, not eroding kind, whereas squamous cell carcinomas are usually eroding kind, less than expansile kind when it comes to the bone involvement.
Now, what sort of investigation you would like to do?
So, Dr. Gopi, you
on
said
imaging.
Yeah, go on.
On imaging, sir, I like to get both MRI more than CT, but I like both.
MRI more than CT. Okay. So
any other imaging you want?
Yeah. And why?
Any other imaging you want to add?
Actually, nuclear scans, sir, they're involved. They can be done in T3, T4, but it's not. It has a weak recommendation.
Sorry, what scan?
What?
PET scans.
PET scan. How about a simple CT chest?
Yes, sir, I thought only for the primary. Yes, sir. CT chest is done.
Yeah. So shouldn't your workup include both?
Yes, sir.
Why? Especially when you have this diagnosis, adenoid cystic carcinoma.
Sir, adenoid cystic carcinoma has an incidence of around 4 to. It's having around 1.5 to 3% incidence of distant mets, most common being the lung, and in higher stages of T4A, it still increases, and in higher grade also it increases more than 3%.
Correct. So high grade, high stage adenoid cystic carcinoma has higher incidence of lung metastasis at presentation.
Yes.
So at the very least, you should image your chest.
Yes, sir.
So in the MR of this patient, what would you look at?
Sir, I like to look for the involvement of sublingual gland. I would like to look into sublingual space and involvement of tongue muscles, extrinsic and intrinsic, and involvement of marrow of the bone, involvement of nerves, posterior extent, inferior extent. And I want to clearly define the extent of the tumor, involvement of the muscles, bone, muscle, marrow, nerve.
Perfect.
So,
Doctor here, this is Dr. Lakshmi Narasimhan. Can you just let me know what are the things which you look for in an MRI when the nerve is involved? What are the things
That will
When
make
the
you.
nerve is involved in MRI, sir, the first thing that happens is there will be loss of perineural fat, increase in the perineural edema, and increase in the tortuosity of the nerve, and the confirmatory sign is widening of the foramina and direct gross involvement of the nerve.
Okay,
So-
Dr. Gobi,
Good.
how will you differentiate benign and malignant by your MRI finding for a salivary gland tumor?
Until unless there is invasion, ma'am, in gross invasion, differentiating between the benign and malignant without histopathology report, it cannot be done, ma'am.
Is there anything like
No,
a
doctor.
diffusion coefficient for MRI? What do you
Yes, ma'am.
mean by a diffusion weighted MRI?
Yes, ma'am. Diffusion weighted MRI is something which gives the satellite, even the minor possible satellite lesions can be seen in the diffusion weighted MRI. It can
Yeah,
be done in both T1 and T2.
Yeah, for this apparent diffusion coefficient in this tumor can differentiate between benign and malignant. If the coefficient is less, it is cancer, and if it is more, it is benign. You just read about all these diffusion coefficient and techniques in MRI scanning so that you can differentiate benign and malignant.
Yes, ma'am.
In addition to that, what you've already mentioned, the presence of nodes, presence of bone involvement, especially marrow involvement, if any, and presence of PNI would all point towards
Malignant.
correct. What is the incidence of nodal metastasis in minor salivary gland tumors at presentation?
At presentation, sir, in minor salivary gland tumors, most commonly the nodal presentation, and if we remove the mucoepidermoid carcinoma, which has an high incidence of metastasis of 60%, if it's a high-grade tumor at the presentation, the rest of adenoid cystic followed by S9 cell carcinoma have an incidence of around 3 to 6% only, sir.
Okay. Right.
So, Snehal was. Yeah, go ahead, Abhi.
Go on, Kanan.
So Snehal was asking you about examination under anesthesia.
Yes,
Is
sir.
it important? And if you do for this patient, what all you would look at?
Sir, I would basically look for the involvement of the, if I can see there's how much floor of mouth is involved, the inferior extent and the posterior extent are the only thing that are concerned if I want to operate this patient.
Correct.
I look for the involvement of these two areas. If these are too free and I feel I can get a margin in those, then I'll go ahead with the surgery.
So if this is you're talking about surgery. So if this is a squamous cell carcinoma, how would you plan for your surgery? If it is adenoid cystic carcinoma, how would you plan for your surgery? What will be the difference? What will be your thought process?
Sir,
for a
if
minor
it's
salivary gland versus squamous.
Sir, basically, the major there is actually, as per the guidelines, sir, we have to treat both in the same way. If it's a minor salivary gland tumor, as both squamous cell carcinoma and minor salivary gland tumor should be treated in both. Until we are severing the nerve in adenoid cystic carcinoma, I would like to go for an intra-frozen section of both the tumor and the nerve. In squamous cell carcinoma, I wouldn't want to do that.
Okay, if you do an examination.
Sir, go ahead, sir. Okay.
So if when you do an examination under anesthesia and you find that the bone, you have you could able to insinuate a finger between the bone and the tumor.
Sir.
So when will you sacrifice the bone, or you wouldn't sacrifice the bone?
Sir, if I have to get a margin and if I am unable to, if I am able to insinuate the finger, then if I am getting the margin of around 1.5 to 2 centimeters, then I'll go along with the marginal mandibulectomy. I would not like to do a segmental.
Any other reason when you will do a segmental other than marginal?
Okay, so doctor,
what is paramandibular?
Paramandibular disease, sir. Paramandibular disease itself is an indication for segmental mandibulectomy. But if I am able to insinuate the finger between the lesion and the mandible,
then you might even try to preserve the margin. You might not even need marginal. If you are not able to insinuate, and then you would look for the paramandibular spread, and the paramandibular spread on the lingual side is quite more. So you would have to do a segmental more often than not.
Yes.
So Dr. Gopi, I'm giving you a hypothetical scenario for this case.
Sir.
You've done an EUA, you've done an imaging. There is no bone involvement. Your marrow signals are normal. You've done a corroborative CT scan also, which shows no cortical erosion. But you see that there is soft tissue. There is paramandibular spread on the lingual aspect of the mandible for a distance of, let's say, from the midline to the second molar. How are you going to manage this now?
I'll take a segment, sir, because once I take the lingual plate, the rest of the mandible is usually weak. The myloid part is usually the part where the myloid attaches is the strongest part. If I am going to sacrifice that, it's better I go for segmental. And if the patient is edentulous, I'll go for segmental. If the patient has prior RT, then I'll go for segmental.
Correct. What is the other issue with a lingual plate marginal mandibulectomy in this case in particular? What problem you might anticipate?
Lingual plate extension. Actually, if I am planning for this lingual plate marginal mandibulectomy, I have to from the posterior extent till the arch and to the contralateral part. I have to take out the mandible into two parts completely. Both.
Correct. So apart from the technical thing, the other thing is this patient will definitely receive post-op radiotherapy, right?
It's
if you do a large resection of the lingual plate, then the chance of osteoradioid necrosis increases considerably.
more.
Yeah. So let's say you're doing, once again, going on hypothetical. Let's say this particular lesion is restricted to is not crossing the midline. Okay, let's say giving you a hypothetical scenario.
Yes,
it's abutting the mandible, for which you will be required to do a segmental mandibulectomy.
Yes, sir.
The lesion is extending through the mylohyoid muscle on both sides of the mylohyoid muscle.
Both sides of the mylohyoid. Yes, sir.
Yeah. What is your resection going to be? The entire surgery, resection, any reconstruction, and anything else?
So I'll go for segmental mandibulectomy. And I'll not try to preserve the lingual, and I'll check for the hypoglossal. If I can get the margin with hypoglossal, then I'll preserve the hypoglossal. If not, I'll resect the hypoglossal also along with the lingual. Now, and in the reconstruction part, I'll go with free fibula if I have to resect the complete mandible or a segment of the mandible with involving the arch.
Two questions in specific. Will you address the neck? Will you send a frozen at the lingual nerve?
I'll send the frozen for the lingual nerve, sir, and I'll address the neck. I'll address the neck for sure. Sure.
Why will you address the neck?
Sir, once there is involvement of mylohyoid, once there is infiltration of the mylohyoid, then the chances of it becomes a high grade stage, T4A stage. In the case of T4A stage, the addressing of neck is indicated as per the ASCO guidelines, sir. Okay. Up to levels 1, 2, 3, 4.
Right. Also, since you're opening the neck for your reconstruction,
we have
to. It is advisable that you address the neck.
Yes.
Okay.
So, Gopi, this is T4A N0. So, what are the specific indications for a prophylactic neck resection in salivary gland malignancy? You said you address the neck in this case because it is T4. It's high grade and high stage because adenoid cystic carcinoma is high grade. So, high grade, high stage. Any other indication for addressing prophylactically?
Recurrence. Recurrent. If there is history of RT.
Yeah. And other high grades like squamous cell carcinoma or carcinoma expleo. Yeah. All those high grade, high stage and recurrence. So you said in this case it's a wide excision, and I didn't understand what sort of mandibulectomy you will do. Segmental mandibulectomy. And any prerequisite for this patient before you take up for anesthesia and surgery? What consent specifically you want to take? Whether you will be able to intubate properly in this case?
No, ma'am. We'll take for a tracheostomy. We'll ask for a tracheostomy, ma'am.
Yeah, either a fiber optic intubation or a tracheostomy might be required. So you have to take the consent for a tracheostomy in this patient.
Yes, ma'am.
Yeah. So what about the tongue? You are going to preserve it, or you said the tongue is pushed?
Yes, ma'am. The tongue is based on the clinical gross appearance, the tongue is not involved, ma'am. If there is no involvement of muscles of the tongue, then the tongue can be spared in the surgery.
What about, you said it's a floor of mouth disease and it's an adenoid cystic carcinoma. So what all nerves will be involved in this? Definitely this will have a perineural spread. So you said you will preserve the tongue, but what about the
lingual nerve, alveolar nerve, and a hypoglossal nerve are the three nerves in the vicinity of the tumor. Depending upon the MRI findings and infiltration onto the surrounding tissues, I'll look into it. If there is involvement of mandible with the peri-alveolar foramen involvement, then I'll sacrifice the inferior alveolar nerve, And if it's nearer to the lingual nerve and I'm unable to get a margin, then I'll sacrifice lingual and hypoglossal.
So definitely with frozen section control for the nerve endings also.
Yes,
So one thing you said about your MRI, but one thing I forgot to ask you, whether you'll be able to say as a high grade or a low grade tumor by your radiological evaluation without a histopathology?
No, ma'am.
But it's described in MRI in T2 weighted images. It's a hypointense and hyperintense. If it's a low grade, it can be hyperintense, but it's a high grade, it's hypercellularity and hypointense. So in that way, the radiologist can comment even on the grade of the tumor, whether it is malignant and benign. So the specific feature of a salivary gland tumor is actually there may not be any bone erosion, but it can involve even the bone marrow. So it could be something like a pressure necrosis or a bone marrow involvement. The evident bone destruction may not be there as in a squamous cell carcinoma.
Yes,
so all these features can be detected by the radiologist even by MRI.
Yes.
Okay, continue. What sort of reconstruction
We'll go for a free flap.
What sort of free flap?
A free fibro, as we have to, if there is involvement of bone, I will do a segmental mandibulectomy. Then we will reconstruct with free fibula flap. Am I audible?
Yes. For the soft tissue replacement?
Yeah, correct. So
flexor longest muscle, and along with the skin paddle, I think it might suffice. Flexor longest muscle we can harvest now for the defect, and it's a floor of mouth until unless there is gross infiltration and big defect. Flexor longest along with the skin paddle, I think it might suffice. If I need more, then I can plan for a double flap also.
So what are all the signs of inoperability in this patient? What will you look at before venturing it? When will you back out or when will you stop your surgery?
In adenoid cystic carcinoma, sir, the major intention is unless I have metastasis more than 5, which I can't address.
Metastatic, done. Next, intraoperative finding. Yeah.
Intraoperatively, sir, if I am unable to
examination under anesthesia, when would you back out? When would you not take him up for surgery?
Posterior margin, sir. I'll check for posterior margin and inferior margin, hyoid and base tongue. In the rest of all conditions, I'll operate.
So hyoid, base tongue. Laterally, tonsil, parapharyngeal space.
Sir, if I feel there is tonsil involved, I'll go for a tonsillectomy.
And parapharyngeal?
Parapharyngeal.
If the tonsil is involved and if the superior constrictor is involved,
then if carotid and if I can spare carotid and IJV, then also we can go for a surgery. Adenoid cystic carcinoma.
Usually parapharyngeal space involvement of a tongue lesion unlikely to come out with surgery.
But adenoid cystic carcinomas are usually well defined in the margins.
Well defined in the margins.
Okay. So, Dr. Gopi, since you mentioned, do we have time?
Yes, sir. Yeah. Sorry.
Okay. Since you mentioned, let's say this on imaging and on your EUA, the lesion is reaching up to the hyoid. Okay. Sir. And on imaging, it shows extension in the pre-epiglottic space.
Sir. If it's going for pre-epiglottic space involvement, I'll go for supraglottic laryngectomy if I can do it along with the resection.
And the lesion is also closely abutting the extrinsic tongue musculature, such that margin will require resection of the tongue.
We can go
also the floor of the mouth, and also extending. On EUA it's reaching the hyoid. On MRI it's reaching the pre-epiglottic space. What are you going to do in such a scenario? Very hypothetical, but since you don't have the MRI, I'm putting this to you.
Total glossectomy with partial pharyngectomy along with supraglottic laryngectomy with reconstruction by using free fibula and PMMC and bilateral leg dissection, of course.
But total glossectomy with supraglottic laryngectomy, don't you think this patient will aspirate? Will have intractable aspiration?
Sir, aspiration can be a problem. Then we can go for TL, total laryngectomy. But in supraglottic laryngectomy, arytenoid is the most important mechanism that prevents the aspiration. If I can spare both arytenoids, and the patient's RLN is preserved, then I think that much severe aspiration can be avoided.
Okay. So maybe I'll stick my neck out right away and I'll say I'm not entirely convinced with this line of treatment. Let's say what the other examiners say.
I'm sorry.
So correct. When you remove that, when you do a total glossectomy along with supraglottic laryngectomy, you'll be removing the epiglottis, you'll be removing the tongue, you'll have an insensate flap all the way from the tongue to the supraglottic area. So what is the second stage of swallowing? If you know that, then you'll know whether this patient would aspirate or not.
Pardon, sir?
What is the second stage of swallow? What are the stages of swallowing?
It's oral, oropharyngeal. There are 3 stages. First is oral, oropharyngeal, correct, and then esophageal. Yes.
Correct. So what happens in the oropharyngeal phase?
In the oropharyngeal space, the food bolus is pushed back by the oropharyngeal tongue. Soft palate covers the nasopharynx. Epiglottis is pulled up by the laryngeal musculature so that we don't aspirate.
So epiglottis is pulled up and your laryngeal elevation occurs. Yes, so sir. Both wouldn't happen in this stage. And yes, second, for your esophageal phase to set in, there should be some sensation. So yes, the sensation is also knocked off. So yes, as Abhishek says, this patient will have high risk of aspiration if you just do a total glossectomy and supraglottic laryngectomy, even though you preserve your bilateral arytenoids.
Yes, okay.
Yeah, even I agree with Dr. Abhishek. Yeah. When you do such an extensive surgery, you can't have aspiration. If you are doing so extensive, you have to do a total laryngectomy and then keep him a better airway rather than backing on that you will not have aspiration.
So after
if you are venturing on surgery,
laryngectomy and all, will you be able to close your tracheostomy? Will you be able to decannulate him?
No. In TL, ma'am, the laryngectomy is permanent.
So Gopi, what are the indications of radical radiotherapy?
Sir, radical radiotherapy in the primary setting, sir, in the adjuvant setting, sir.
And radical radiotherapy is radical.
So, Dr. Gopi, radical means definitive. So definitive. What setting can it be?
So what will be the indication then?
Sir, in the case of adenoids, in the case of salivary gland tumors, the only indication is if the patient is inoperable.
So what is inoperable and what is unresectable?
Yes, sir, correct.
So that is what I was pushing you towards, Dr. Gopi.
Okay, sir. Sorry.
The imaging findings which I described, these all can be, gotten out. But are they worth doing?
No, sir. Actually, that few highly morbid surgeries. And in the case of adenoid cystic carcinoma, with a survival rate of 5 to 10 years up to 80 to 69%, 89 in 5 and 10 years, 67%. If the patient is willing, then.
And the quality of life which you give after such a morbid surgery is also quite important. He will live 10 years.
Yes.
Yeah, this is, although it's an intolerant cause tumor, this is high grade and highly aggressive and known for its recurrent pattern. So if you go for a total glossectomy and supraglottic laryngectomy and all, the patient will have intractable aspiration, and unless and until you close the tracheostomy, you won't be able to have the patient with a normal feeding. So it's better to avoid such morbidities in this patient, such patients, because of the back survival. So what are the sites of recurrence, or what area you expect such recurrence in this patient?
Most common site of
yeah, because of the perineural spread.
Most common site of is along the nerve, and if the margins are closed, then they're followed by nodes.
Yeah. The skull-base recurrence is very common for such patients, because otherwise you have to have a frozen control and resect up to your foramina.
Yes,
in adenoid cystic carcinoma. Yeah, we have often seen recurrences at the skull base in adenoid cystic carcinoma, and also lung metastasis. When will you go for metastatectomy in metastasis to the lung?
Sir,
is it justifiable for an adenoid cystic carcinoma?
Yes, ma'am. As
per lobectomy?
Yes, ma'am. As per the guidelines, if we have metastasis less than 5, then we can address them with a local therapy, surgery or ablative.
Okay.
The way you should answer it is oligometastatic disease, which is less than 5, unilateral, no pleural affection. Primary is either controlled or controllable.
Okay.
Okay,
Yeah.
without extensive morbidity.
Yes.
All right. So, do you know of any specific type of radiation which has shown extraordinary benefit in salivary gland tumors?
Proton therapy, sir.
Proton
What does
therapy?
the evidence say? Is there any evidence for proton?
As per and evidence,
For
statistical evidence is not there, but they say proton-based beam therapies have good effect in the salivary gland tumors than rest of all.
Are you
So
aware
other
of the?
particle.
Are
What
you
are
aware
other,
of the? Yeah, correct. Are you aware of the MRC trial? Any other type of therapy?
Correct.
No, I'll read it.
So read up the MRC trial.
Yes, sir.
RTOG MRC trial for neutron. But why so proton and all are good enough? Why are they used for salivary glands, especially for those where they are close to the skull base or close to the eye, the critical structures? Why so proton is good enough? Why so carbon is good enough? And why so neutron is good enough?
They are heavy and they penetrate minimal distance, sir. They can transfer high energy to the minimal distance. So there will be sparing of OIR and maximum effect at the impact. So when the beam strikes, there will be.
what is Bragg's peak?
Correct.
Pardon?
What is Bragg's peak?
Bragg's
peak.
What is Bragg's peak?
Bragg's peak. No, sir.
What is that ratio called?
Bragg's peak. I have no idea.
No, there is rapid fall and rapid.
Yes, sir.
You don't have scatter effect. The surrounding tissue will be protected.
Yes.
So, like deposition of energy will be like at a targeted region. So that's why protons are good. High energy, carbon ion, and all those things are good.
And salivary glands don't multiply quickly. The cell cycle is slow.
Very slow.
So if it is slow, it is not able to repair the sublethal damage that your proton or your neutron or your carbon will cause. When it's not able to correct, it will undergo lysis. Yeah.
Yes.
Yeah, Gopi, there is a couple of questions in the chat box. Suppose if you have a T2N0 lesion on the heart palate, what is the extent of your surgical resection?
T2N0 in the heart palate, unilateral, bilateral, midline.
Yeah, suppose if it's in the midline T2N0 minus salivary gland tumor.
Yes, ma'am. I'll do total infrastructure maxillary, and I'll try to reconstruct. I'll remove the whole palate.
Yeah. So how will you reconstruct?
By a free flap, mostly by the ALT or ALT and free fibula.
Suppose if it is a small lesion on the heart palate midline, whether you will advise an obturator rather than going in for a major reconstructive procedures?
Yes, ma'am. If I can spare the alveolus, then I can ask for an obturator. If I am unable to spare the alveolus, then I'll go for a reconstruction, depending upon the extent of the resection.
So by that, till what extent you can use an obturator?
There should be minimum. One side of the alveolus should be spared. Minimum of the incisors to the molars should be spared so that we can fix the obturator there.
It is always canine. Gopi, check
What forms the fulcrum? What forms the fulcrum?
What forms the fulcrum?
Canine.
Correct.
So is it just the a horizontal resection which is important, or even
vertical?
will you figure out a vertical? So till what extent vertical you can use an operator, beyond which you would need a micro reconstruction or whatever?
Sir, up to if I can If I can spare the inferior wall of the, if I can spare the superior wall of the maxilla and anterior wall of the maxilla, then I can go for the operator.
Why you can't you use it for anterior wall of maxilla? If you remove the anterior wall, operator can't be used.
Operator can be used, but for the aesthetic purposes, reconstruction would be better.
So, what are all the types of operators you know?
Operators.
Is there any different types of operator? Since you are mentioning about the contour on the anterior wall, and how would you prevent contour deformity by using an operator when you excise the anterior wall?
No, sir, I'll read it.
So no, this is basic. There are three types of operators. One you use surgical operator, which you use to keep the pack on hold and other stuff. Second, you'll give an interim operator. So when you do a resection, the contour deformity occurs when your anterior skin flap gets stuck to the posterior wall. You would like to prevent it. That's when you put a skin graft in that area and you put a pack so that the flap doesn't come behind. After 5 to 10 days, you would give an interim operator, which gives a small stuffy bulge on that area, which would keep the anterior skin flap away from the posterior wall. Then once the patient completes his radiation, you would give a final operator, which would have an upper bulge and it will also have a teeth. So the three types of operator is quite important when you plan for any resection or not for a reconstruction.
Yes, thank you.
Yeah, Gopi, suppose if this is a very old patient with a T2 disease and the edentulous patient, you won't be able to put an obturator and the patient is not fit for a free flap reconstruction. How will you manage the oroantral fistula? Whether the patient will be on a permanent right strip feed or any other local flap reconstruction you can
We can go for an island. We can go for island nasolabial tongue flap or buccal mucosa flap, fan flap.
Yeah.
Any muscle flap which can be brought here?
Any muscle tongue flap? Okay, this suprascapular artery.
How about the temporalis flap?
Right. Temporalis flap can be brought. Yes, sir.
So it is an effective reconstructive option in
palate, maxillary
in constrained settings, just like what Elizabeth Madam said.
Yeah, island nasolabial temporalis flap or island submental flap, all these are for local reconstruction. The only issue will be the oncological safety if you go for a submental flap or a hair growth in male patients.
Yes.
Otherwise, if you go for an adjuvant radiation, the hair growth can also be lessened. So what are the indications for adjuvant radiation? Suppose if it is a T2 lesion on the palate, you resected it, and then when will you go for adjuvant radiation for minor salivary gland?
There are indications if it's there is close margins and PNI positive. Close margin, PNI positive, high grade.
High grade.
Grade is very important. Also intermediate grade.
Yes. Yes, ASCO.
So go on.
Actually, ASCO guidelines in 2021 mentions only high grade. Intermediate grade has.
Okay. What? Okay, I would agree with that, but I would irradiate most of my intermediate grades as well.
Yes, sir.
See, adenoid cystic carcinomas, I would irradiate most.
Yes, sir. Mucoepidermoids.
Yeah, I'm saying about adenoid cystic carcinomas.
Yes, sir.
So I also sort of agree with Abhishek. I would irradiate most of my minor salivary gland patients, which are not low grade and which are not even T2. Anything beyond intermediate and high grade, anything beyond T2 would get radiated post-operative.
Yes, sir.
Yeah, Gobi, having said that, I'll give you a clinical scenario. An incomplete surgery done from outside referred to your cancer center. That was a floor of mouth lesion. We have just taken an excision biopsy or something like a wide excision they have done. But the slide review is showing that margin is positive. On clinical examination, nothing is there on the, clinically nothing is there in the floor of mouth, but the margin is positive. It is a 50-year-old male patient. How will you proceed?
I'll go for a slide review. Then if the margin is still close, if the margin comes close, then I'll go for adjoint RT, including the primary site. And if the neck is not addressed, involving the neck, including the neck.
Adenoid cystic carcinoma, margin positivity, incomplete surgery from outside, and clinically nothing is there. Will you go for a rewide excision or for adjoint radiation?
Adjuvant radiation, no resurgery.
Suppose if it is a mucoepidermoid carcinoma.
Mucoepidermoid carcinoma, if there is nothing clinically, only margin positive is not an indication for resurgery. Only adjoint RT is indicated.
No, there comes the grades again. Low grade, intermediate, and high grade. Adenoid cystic carcinoma is definitely high grade, and definitely adjoint RT is required. So a rewide excision may not be mandatory in such cases. In mucoepidermoid, it is different, no? Low grade, intermediate, and high grade. Yeah, then if it's a low grade tumor, maybe you can avoid an adjuvant radiation. So you can take up the patient for a rewide excision, close it with skin graft and all, and then that's it. Maybe you can reserve radiation for a later date for any other.
If clinically there is nothing, how to decide about the extent of the surgery, ma'am?
Yeah, that's what. How will you investigate that patient? What sort of radiological evaluation you do, and when will you do?
After there should be a gap of minimum 1 month for the edema to subside. Then I'll go for an MRI and CT thorax.
Yeah, MRI doesn't show anything, clinically nothing, but margin is positive.
Then if I have prior clinical picture, then the extent can be decided. Otherwise,
yeah, maybe you can take it in this way. If it is a high grade, like adenoid cystic carcinoma, definite adjuvant radiation is required. So you may not need a rewide excision, but otherwise for low grade tumors, maybe you can go for a rewide excision and that's it. So in that way, we treat our patients because you can avoid a radiation for a low grade tumors or a intermediate. But if margin is positive, then you have to go for a rewide excision.
yes.
Dr. Gopi, any targeted therapy you can use here? Are there any targets in adenoid cystic carcinoma? We alluded to it earlier during our pathology.
Yes, sir. As per the guidelines, they say TKI inhibitors can be tried. TKI inhibitors like livotinib and sorafenib can be tried if it is in a clinical trial setting only. And in case of metastatic disease, which is not amenable for definitive therapies.
What are the targets here? What are the targets?
One is FLT3 and one is VGFR.
How about c-KIT? c-KIT is one of the most studied targets in adenoid cystic carcinoma.
I need a project.
What VEGFR? 1, 2, 3. What VEGFR?
3, sir. VGFR 3.
Yes.
How will you follow up this patient?
Ma'am, as per the guidelines, when we can have imaging for every month after 3 months, then for 6 months. 2 imagings in 2 months, followed by imaging every year. And after 3 years, if everything is negative, then we can just follow up the patient without any imaging.
I didn't understand. Monthly imaging or yearly imaging? What did you say?
First 2 months, for the first 6 months, we can have 2 imagings. After 3 months and at the end of 6 months, if there is nothing clinically and radiologically, then we can follow up the patient with yearly imaging for the next 3 years. If there is nothing in the 3 years, then we can just follow up the patient and no imaging is further required.
Dr. Gopi, I'm not aware about these guidelines, but I think 2 months is too early for a post-op imaging.
Imaging of the primary or the X-ray chest? What do you mean by imaging here?
Imaging for the primary.
Imaging of the primary, that's too early.
2 months is too early.
3 months.
Yeah, yearly chest imaging is mandatory for adenoid cystic carcinoma.
Doctor, I just wanted to ask you questions.
Sir?
The history, you showed such a big mass in the oral cavity.
Yes, sir.
Does the patient doesn't have any swallowing issues, like he is able to take oral feeds?
I said swallowing issues.
Nothing.
Swallowing difficulty was chief complaint.
No, I'm asking, is he able to sleep normally? Is he not having any like rider or something like Something should be there, no? Such a big mass in the oral cavity. You said the tongue is moved to one side. He's taking oral fits normally. Yeah?
Yes, sir, he's able to take semi-solid diet.
What is the etiology in this case? What etiological factor in this case?
Etiological factor in this case. But
what are the etiological factors for minor salivary gland tumors in the oral cavity?
Most common are environmental, genetic, and lifestyle factors.
What are the viruses associated?
CMV is usually nowadays associated with adenoid cystic carcinoma.
Epstein-Barr virus.
Yes, ma'am.
HIV, CMV, all these, the viral associated. Any other occupational exposure?
Yes, ma'am. Leather industry and wooden industry can positive, but they are most common in the sinonasal cancers than flora of mouth and oral cavity cancer.
Yeah. What is the association with tobacco?
Tobacco, ma'am. Actually, there is no in the association of tobacco. They say it can be there can be decrease in the survival, but association with tobacco with minor salivary gland tumors is not yet established.
So coming back to that, compare this with the squamous cell carcinoma. Let's say you have a similar tumor, which is now a squamous cell carcinoma. It had a small superficial, small mucosal ulceration, and all this component was submucosal.
Yes,
what are your, how is your workup going to be any different? How is your resectability any different? And what, is your surgery going to be any different?
Can you repeat? Actually, I couldn't follow up.
Okay. Let's say this is a squamous cell carcinoma.
Yes, sir.
What are the differences in your workup, resectability, and the extent of surgery?
Yes, sir. If this is a squamous cell carcinoma, then the size is same, sir, 18 to 6 centimeters with floor of mouth.
Sorry?
It's in the floor of mouth with 18 to 6 centimeters, huge growth, sir. Then I'll go for as it is high staging, sir. Then I'll go for MRI, CT, and CECT chest. HRCT chest. If I'm doing contrast and CT scan of oral cavity, then I'll go for CCT chest. Okay. The surgeries are wide local excision, segmental mandibulectomy. Then I'll go for bilateral neck dissection along with free fibular flap. If needed, double flap.
So does your criteria of resectable if there are less than 5 mets also apply to squamous cell carcinoma?
Less than 5 mets, no, sir.
Why not?
Because even if there is metastatic disease in the squamous cell carcinoma, the prognosis of the patient and survival of the patient in post-C is very low in squamous cell carcinoma when compared to adenoid cystic carcinoma. So even we operate this patient with the metastatic load, the survival is around 30%. In adenoid cystic carcinoma with the metastasis, even the survival is not affected by the oligometastasis in the lungs. It is still 80 to 60%. So operating in adenoid cystic carcinoma is justified than squamous cell carcinoma.
So outcome of metastatic squamous cell carcinoma is uniformly poor.
Yes.
And therefore is a contraindication for surgery.
Yes. So you told it's about 18 to 6 centimeters squamous cell carcinoma, floor of the mouth lesion, almost tongue fixed. Would you want to operate?
Tongue is fixed, sir. In this tongue is fixed, then we can go for total glossectomy.
And let's say it's abutting the mandible. So this is going to be a total glossectomy with more than half the mandible resection.
Correct.
Are you going to operate?
Yes, sir.
Or you want
if
to
I can
test the
spare,
biology,
or
you want to test the biology of the disease before venturing.
Actually, there are no definitive factors that can say that tumor might be aggressive in the tumor biology.
So what we are trying to ask you is, such a morbid surgery,
sir,
would you venture in straight, or do you want to try something else and then come for surgery at a later stage?
NACT followed by surgery can be attempted.
What are all the criteria for you to give NACT in a squamous cell carcinoma of this extent?
Sir, involvement of the soft tissues till the zygoma, infratemporal fossa, in the zygoma.
They are inoperable straight, no?
According to the study by VM Patil, the indications are given as involvement of skin and soft tissue till the zygoma, Sopranos disease, edema till the hyoid.
Okay, edema till the hyoid. Okay.
And involvement of base of tongue and vallicula.
So for us, no, I don't know. For me, if it is quite a morbid surgery, for example, you're dissecting the mandible, and for the total glossectomy, for a squamous cell carcinoma, before venturing, and I would give neoadjuvant. If the tumor shrinks, then I would operate. If the tumor is increasing, then to me it's quite inoperable. The morbidity is quite high.
Yeah, apart from morbidity, when the survival is really low, for a T4 lesion, maybe in a young patients, we can try this neoadjuvant chemotherapy as a surrogate marker to assess the biology of the tumor. If it responds well, maybe you can take up the patient. Otherwise, better to leave him for a palliative treatment in total ankylosing. Survival is really poor. Gopi, you specifically mentioned for dysphagia for solids, not for liquids. What does that mean?
Actually, I felt when the patient said it, I thought the patient is unable to complete his oral and oropharyngeal phases of swallowing. But the liquids he was unable, he was just taking by using a straw, so that he is using the gravity as, I thought gravity as.
Okay, that means that there is no aspiration. It's just difficulty in swallowing for the solid food. So if it's for liquids, then the pathology may be different. That's what. Either a penetration or an aspiration. It should be like a nerve paralysis, or it's lower down, laryngeal. Okay, dysfunctional larynx and all. So if it's oral and oropharynx, maybe for solids, and if it's larynx, it could be liquid.
Sir, I just wanted to ask other examiners. In this case, would you like to resect the tongue, or as he said, you will preserve the tongue?
Lakshmi, when this would be, to me, it looks like a sublingual gland tumor. When we resect, it would be definitely aborting the genioglossus muscle. So, so significant amount of genioglossus muscle will go, and almost you'll end up something like a hemiglossectomy. At least the ventral, the dorsal aspect of the tongue will go. You can't preserve the tongue in this patient, even if it is arenacistic.
Yeah, because lingual artery is going to be there in case, like within the tumor mass. You are not going to dissect that and then.
That's the point I want to mention. Bilateral lingual might be sacrificed, so this will devascularize the rest of the tongue. You won't be able to save the tongue. Maybe the posterior part of the tongue will be preserved. Otherwise, it is really difficult to, by ligating both lingual arteries, it's difficult to preserve the anterior two-thirds of the tongue here.
Yeah, majority of the time when you have a floor of mouth lesion, you have to get the lingual hypoglossal and lingual artery. On that side. Yeah, all these things on that side has to come out because they are the embryological origin. So you can't just dissect, cleave it, and especially in case of minor salivary gland tumors or arenacistic tumors, you have to try to get good margins, and especially on the neurovascular bundle.
So if it is one side, he'll lose the tongue. It will be something like a compartment resection of the tongue on that side. If it is crossing the midline to significant extent, as Madam told, it will be an anterior two-third glossectomy or subtotal glossectomy. Nothing less than that. That's what doing this with the mandible is quite a morbid procedure.
And in this case, I think after a CT assessment, if the bone is intact, maybe we can preserve the mandible and do the wide excision of the lesion, maybe along with anterior two-third glossectomy and a soft tissue reconstruction. Like even a pectoralis major flap is also good for such case, or an ALT flap or microvascular free flap. But we have cases like this with the salivary gland malignancy. The whole tongue or floor of my mouth has to be resected, but mandible can be preserved. And then you can put in a tunnel in a pectoralis major flap, which might form as a floor of mouth, but still it is good. Or you can put an ALT flap also. If the bone is preserved, then the patient will be able to swallow, and some sort of speech rehabilitation and swallowing rehabilitation can be given. So Gopi, after your extensive resection in this case, if you had done a glossectomy, a floor of mouth resection, and segmental mandibulectomy, what are the rehabilitative measures you need to adopt for this patient?
One, I look for speech, swallowing, and functionality of the patient. Speech, swallowing, and functionality. If we have as they say, if we can't preserve the tongue in this patient, then the speech rehabilitation is almost zero, almost nil, and then swallowing can be done with the Mendelssohn's maneuver and all. Functionality can be done by the rehabilitative medicine department, where the patient is moved from the work where he has to speak and all. He can be converted to a place where administrative measures to move the patient to a place where he can work.
Yeah, the oral phase of swallowing is affected because there is no bulk for the flap, bulk for the tongue. And so the tongue has to touch the palate to push the food backward. So any other adjunct you can use to provide help for the oral phase of swallowing. There is something called a palatal drop prosthesis, so which can be fitted as an obturator on the palate. And if you have a minimal amount of tongue tissue, that will push the food backward. That way you can help the patient in swallowing. And also the aspiration has to be prevented. So different techniques of swallowing has to be taught to the patient. And for the speech, definitely the tip for the other subunits are say GB sulcus, the bulk of the tongue, everything is essential for a proper speech. So speech is also affected. So you should have a speech therapist, speech pathologist to help him. And if you have gone for a neck dissection, then the shoulder exercise has to be taught. So all these are the rehabilitative measures you should adopt.
If you do a total glossectomy in this patient, would you do any particular technique to prevent aspiration intraoperatively?
We can close if we have total glossectomy, sir, there can be permanent closure of the glot. There can be permanent closure by using AEF. We can stitch the AEFs together.
AEF holds together.
No. When you do a total you are doing a total glossectomy for this patient. Is there any surgical technique which you do or surgical step which you would do to decrease aspiration, or to aid any step of the swallow, any phase of the swallow?
See what happens when total glossectomy is done.
Oral and oral.
No, what happens? What happens to the larynx when total glossectomy is done? What happens to the larynx?
It can't be pulled up actually.
So anything regarding that? Can you hitch the larynx up?
Yes, sir.
Yeah. So isn't that an important step?
Yes, sir.
So one more question. After a segmental mandibulectomy,
ma'am.
So the major issue you come across is a malocclusion, because the normal mandible will be pushing towards the opposite side. So how will you train the patient to avoid this malocclusion after a segmental mandibulectomy? There will be chewing issues. They won't be able to chew properly. So after the segmental mandibulectomy, how will you train such patients for preventing this malocclusion?
Introp, actually during the introp, I'll try to remove the stresses on the stump of the mandible. I'll remove the pterygoids and masseter, so that the mandible is free. The stump of the mandible is free. Then I'll go on with the reconstruction, and during the in the postoperative phase, I'll ask the patient to take foods from the side of the mandibular stump. Then on the reconstruction phase.
So suppose if you do only the soft tissue reconstruction only, I was asking that problem. So if you do a free fibula, the situation is different. If you put a locoregional flap like a pectoralis major, there is definitely going to be a long-term mobility of a malocclusion. In such cases, you have to train the patient to do some exercises to prevent this, to push the normal mandible towards the side, and also to use such guiding flanges to prevent this. Okay. So definitely the help of the prosthodontist is mandatory here.
So not specifically about adenoid cystic carcinoma of this case, but what is treatment package time?
Sir, including the surgery, RT, the surgery should be completed and the RT should be started within 8 weeks and should be completed within 100 days.
So how will you ensure that this timeline is maintained?
Once I get the incisional biopsy report, if the patient turns out to be high-grade adenoid cystic, I'll inform my radiation oncologist that I am operating a patient on this day. I might need the radiation date within 8 weeks, the date of surgery. So I'll keep the radiation oncologist posted and my pathologist posted for an early report. So that I'll maintain the timeline. The timeline is well maintained. Am I audible, sir?
Yes. So what I was trying to say is that this is this is one of the reasons why your reconstruction has to be good, so that your patient is recovers well in time to start his adjuvant radiotherapy in time.
Yes, sir.
What is the role of chemotherapy in salivary gland malignancy? Any role?
No, ma'am. Only palliative setting. Unless the patient is deemed operable and patient can be amenable for a definitive treatment, there is no role of CT chemotherapy.
Very good, Gopi. You sound very confident. Very impressive presentation. Nice, keep it up.
Thank you.
Good job, Dr. Gopi. I think except for a minor few things which you need to read up, you did a great job. Congratulations. All the best.
Thank you, sir.
You sounded very confident. Your confidence was good.
Yeah, that's what I wanted to comment. He is willing to admit that he doesn't know something and he's willing to read it up. And also he's confidently answering the question. That's a good point.
Thank you.
Best.
I just wanted to tell you that you seem to be a aggressive surgeon.
Absolutely.
Yeah, very confident. Yeah, he's confident in doing aggressive management. Yeah.
Good man, good.
It's my department's training.
No. But you should know when to back out.
Yes,
Okay, it's not about aggressive. It's not about doing
Yes.
bravo surgeries. No.
As the
As
young,
an oncologist, you should have that limit. That beyond this, I'm not going to venture. That
Yes.
line you should determine for yourself. Nobody can tell you. Okay,
Yes, sir.
for a surgeon, you should determine your limit. This is the limit I'll go, and beyond that, I'll not go.
Yes,
Like
sir.
anything and everything can be resected nowadays, and it can be reconstructed. It's not about like we have very good reconstructive teams available. Like you can say anything I can resect and reconstruct. But
Yes,
does
sir.
it going to help the patient? Am I going to
Correct.
benefit the patient by doing such a big surgery, such a big resections? So you need to keep it in mind and then you proceed.
Yes, sir.
Thank you.
Thank
Good.
you, sir. Thank you, sir.
Thank you, Dr. Gopi, for such a wonderful presentation. Indeed, the discussion from all our examiners and the questions asked were all very relevant and absolutely they covered all the topics, right from the management to adjuvant radiotherapy, chemotherapy. There is definitely an emerging role of immunotherapy also in salivary gland tumors, and the role of mutation-directed treatment and hormonal treatment as well. These are some topics which can be asked in examination. And I think before we end our session, anything else as a closing statement from Elizabeth Madam or Dr. Kanan sir or Dr. Abhishek sir or Dr. Snehal or anybody or Dr. Lakshmi of the closing statement. Madam, would you like to give a closing statement, please?
Yeah, as it was said earlier, actually, in very advanced diseases, we should be able to back out in some instances. It's really difficult to convince the patient and the relatives, but sometimes we have to spend some time more in the OPD. That's my experience. We may need to spend 5 or 10 minutes more with such palliative setting patient and to counsel them regarding the prognosis, the survival benefit, and tell them the morbidities associated with the surgery and the possibility of an early recurrence, the financial implications on them. All those things you have to tell them and explain to them properly then. And then you have to tell them about the palliative options in such instances. That is what I wanted to tell the younger generation. It's not like doing everything aggressively and actually mutilating surgeries and then letting the patient to suffer with the family's financial problems and all those things. So in our economical and in our country, with a case volume of very large in our all cancer institutes, we should spend some time in discussing all this in our tumor board and to segregate some patients for palliative intent therapy rather than taking up all. We should have some gut feeling whether this patient really is going to benefit from our mutilating procedures. That's what I wanted to tell as the final thing.
Definitely. Dr. Karan sir, Dr. Abhishek sir, any comments from your side? Dr. Lakshmi?
Yeah, so I think most of the points have been superbly covered during the discussion and now at the end by Dr. Elizabeth Madam. Minor salivary gland tumors, especially adenoid cystic, are some of the tumors where, as compared to squamous cell carcinoma, you can stretch resectability to a little bit. But remember, nothing trumps what quality of life you give to the patient, what is the longevity of that disease-free interval that you give to the patient. If both of these are going to be affected, then there is no point doing heroic surgeries. There is a definite role for non-surgical modalities, and these can be used in a definitive setting. There is emerging evidence about targets which can be used within different types of salivary gland tumors, especially in adenoid cystic and salivary duct carcinoma. So these can be utilized as well.
Thank you, sir. Thank you to all the eminent.
To make one point, just a point.
Sure.
These minor salivary gland tumors are really difficult to manage even for an experienced surgeon. It's not like a tongue well differentiated squamous cell carcinoma. You just go there, resect with the 1 centimeter margin. But these are like anatomical location. These are like really the resection depends on what is the site. Palliative will have a different resection and a reconstruction, and the nerves related. It's quite challenging even for an experienced surgeon to resect these tumors. So you have to be really careful while operating these patients, and you should always think of, you should have in your mind that you will have recurrences. Even if you have good resection, you still have high chances of recurrences in these minor salivary gland tumors. Thank you.
Definitely. Thank you, sir. So our take-home message is that we can resect all the cases, but we have to be very careful when extending our limits of resection, especially in minor salivary gland tumors, because their behavior is definitely not like squamous carcinoma of the oral cavity. And while making decision for oral cavities for minor salivary gland tumors, we tend to take decisions in terms of squamous carcinoma, which we should always keep in mind. Thank you, everybody. Thank you, ma'am. Thank you, sir. And thank you, Dr. Snehal. Thank you, Dr. Gopi, for such a wonderful presentation. Thank you, Kanan sir. Thank you, Abhishek sir. Thank you, Lakshmi sir. Thank you, ma'am. Thank you for your time.
Thank you very much. Pleasure indeed. Thank you.
Thank you.
Thank you.
So much.
Thank you. Thanks a lot.
Thank you. Gopi, be less aggressive.
Thank you, sir. Sure, sir.